Hi everyone, back again. So today it's Facebook. Hello Facebook community. Hope you're all doing well. Thanks for tuning in. So today, interesting. I always get asked questions. So I'm going to ask a question today. If you don't mind, whoever's watching, in the comments, tell me where you're watching from. I mean, you don't need to give me your exact home address and postcode, just the town will do, just so I get an idea. I'm just thinking about, where we're reaching, who we're reaching, and where you are, so I can think about, and don't hold me to this, future clinics. Right, there I've said it. So please, in the comments, where are you watching from? That would be good, just the town would be fine. So today we're going to talk on a few subjects today. So one of the things we're going to talk about is why we reject people. This keeps coming up, doesn't it? Who uses the word reject?
It seems to be a sensitive word, doesn't it? Reject.
Seems to be very emotive. It's not
Yeah.
my word. My word is, you don't need what we do.
Yeah, right.
That's my words. What's this reject thing? It's like, asking someone out and them saying no. I'll never go out with you, ever. Ooh. So, yeah, I don't get that. Sorry, everybody. This is Kalyana. She is one of the coordinators. So some of you may have actually communicated with her. So she's one of the group that picks up the initial inquiry and helps you get to a full clinical assessment. This is Hamza. Hamza is part of our design team. Hamza, you're also a dentist, aren't you?
Yeah, I am.
Right, okay. How long have you been a dentist for?
3 years.
3 years?
Yeah.
Right, and how long have you been with us?
1 year.
1 year. And how mind-bending is that 1 year compared to all the time beforehand?
I would prefer this 1 year over the last 4 years that I have in BDS if it comes to implantology and surgery.
Okay, so what have you understood in 1 year that's so groundbreaking?
So in this 1 year, I've learned like so many things specifically when it comes to dentistry. My prosthodontics, it has been like fully polished. My knowledge in implantology, my knowledge in surgery, it has been like boosted.
So have you learned that what you previously considered was impossible is actually possible?
Yeah,
if you look hard enough.
Yeah, impossible is not a term in here. I mean, we find every possible way to treat. So like we give our best, like 100%.
But do we ever, in our search for helping as many people as we want, do we ever push the boundaries and just do things when we're not sure it's going to work?
Yeah. First of all, we do things that works for us. So we always go above and beyond to, like, for each and every case. We want to treat anyone who wants our help. Whenever we look at the cases, we say like, this patient needs us, whatever like situation is.
Try and find a way.
Yeah, exactly. That's our topic. That's what we are taught by you. Just find out a solution for everyone. Just give our 100%. If let's say we are not sure about any case, we come to you and you then guide us.
And on the odd time when we feel that our solution is not appropriate, and I need you all to understand this because I work with this crew, they're in the office next to me, they get really disappointed.
Yeah.
Don't you? You all take this really personally, and I have to come in with like a box of chocolates or say nice things to all get you to be happy again.
The way we have been taught like this, we try to like help all of you. So we try to find a solution for you. So that's it. Like our top priority is like to do workout for everyone that we can. Like we want to help everyone out there.
Would you say it's good to describe us as bone hunters? Are we bone hunters?
Don't ask me about that.
We go hunting.
We
for
do
every millimeter, every fraction of a millimeter of good vascular bone. We go hunting for it.
We look for it. We go through every area in the mouth, like CBCT. We just like explore every inch of it, and we sometimes, like most of the times, we are successful, and then we say like, we have a solution for you. We can work on you. So that's the thing.
An interesting dynamic that I notice on the group is people get spooked at the fact that we say things like, we've put you into planning. Put you into planning doesn't mean we're going to reject you. Put you into planning means we're going to have an even deeper look with the data all organized. And that's key here. That's absolutely crucial here. That's what needs to happen. You know, we need to get to a point where we know that if this person is going to go through that journey, it's got a really, really, really high chance of working. Otherwise, why are we doing it?
So I will say something about when someone comes to us, whenever any case comes to us in planning, it's like, it's beneficial for them because they will be having extra pair of eyes. The initial planner, the senior in the team, and then it comes to you who finalizes it. And whenever
you seem very happy for a guy that's terrorized by me. You and your entire group are terrorized by me daily.
But it's working in a positive way. Our brain, it's getting boosted, and we are just.
It's called the Stockholm syndrome. It's when you've been abused enough, you just fall in love with your abuser.
Person, yeah.
You understand? I think that's what's happened. Don't you think so, Gordon? Don't you think so?
Yeah.
Because they are literally in the room next door to me, and they can literally hear my door open, and I can just hear this.
Here we go again.
Here we go. Here he comes. He's going to say something, definitely. Yeah, but our responsibility as a planning team is to find the yes. And we really look for the yes. How many times have you heard when the inquiry comes in, they actually say, even with no scans at all, we've not taken a single scan, they'll say things like, I've been told I have no bone.
That's the dreaded line. The dreaded line was,
How many times have you heard those magic words in 12 months?
Too many to count.
Hundreds, right?
Hundreds and hundreds, yeah.
Have we then fixed them?
Yeah, I'll see them in the patient group. I got a yes.
I got a yes.
I got a yes.
Yeah. Look, there's a level of investment in technology in this place. And again, I don't really like speaking about what other people do because, frankly, I just care about what we do. And there's a level of investment in technology here, particularly in diagnostics, analytics, and planning, because that's the cornerstone of everything. If you don't go hunting for every single millimeter, because that millimeter is the difference between having something that works predictably for someone and having something that may or may not work. And then we have to make judgment calls as clinicians. We have to go, does the benefits greatly outweigh the risks? Not outweigh the risks, greatly outweigh the risks, because all surgery carries risk. But are the benefits so profound by searching for that 1 millimeter that's going to make the difference? Going to be the difference between this human being being happy and this human being continuing as they are. So we all get a bit geeky about it, you know, and then you see them on the patient group. Not only I got a yes, but they're also posting 4 months later going, look at me.
Oh, it's so rewarding.
Yeah.
But in the initial inquiry, that's what I know. So it's difficult to translate the confidence to them, although I wish I could sometimes. But
well, you could say, this is all we do, you know.
Yeah. Even that sometimes isn't enough, though.
We don't do anything else.
Yeah.
You can't come here and have fillings done because we don't do them, and we just haven't got enough hours in a day. All we do is we're bone hunters.
Yeah.
We just go hunting for the last millimeter of bone that we can work with.
Yeah.
And I've learned in my career, we don't actually need that much. We need a lot less than people think, and contextualize. I need that much in height, and I need about that much in width.
Yeah.
Now, considering that the jawbone started at that much in height and about that much in width, you'd have to lose a hell of a lot. I mean, like a hell of, and don't get me wrong, it does happen, but it's so rare. In here. That was your paranoia, wasn't it? You didn't think I'd find enough, did you?
Yeah, and I thought I don't have enough bone. Somebody told me.
Who was it? Some fella at a bus stop? Who told you?
I think hygienist. Yeah, exactly.
But wait.
No,
Were they referencing an X-ray when they said you don't have enough bone?
I don't think so.
And then there's two kinds of X-rays.
Yeah.
There's a 2D X-ray, and then there's a 3D volumetric analysis X-ray called a cone beam CT scan. Did you actually see that when they said to you, you don't have enough
It
bone.
could have been only X-ray. That's all. It
But did
wouldn't
you
be-
see the X-ray, or did you imagine
I
her
haven't
seeing
seen
the
it. I
X-ray?
haven't seen
So
it.
you didn't actually see the X-ray,
No.
but it was a you don't have enough bone, or you might not have enough bone. What was the actual statement? Might not have enough bone. But you see, on the might not have enough bone,
Yeah, no.
you might have enough as well.
Yeah, exactly.
It's like a glass
Yeah.
half full,
The-
glass
the-
half empty
yeah,
kind of
two sides.
discussion and debate.
I know you hate maybe more than anything.
Oh,
So
how does that help anyone? How does the word maybe help any
I
human
know.
being in the world? Maybe I love you.
Yeah.
Maybe.
Yeah.
How does that help anyone?
Maybe it's not a word in here. We
We
go for
don't, yeah.
definite.
It's binary. It's yes or no.
yeah.
It's safe or unsafe. That's it. Patients need us to be sure. We're sure we can fix you. We're sure our solution isn't right for you. Those are the answers.
Yeah.
There's none of this, well, you know, we could have a go. Have a go? Have a go? Yeah, we're not having a go. We can either do it or we cannot do it. Zeros and ones, binary, really that simple. Which brings me swiftly to the next bit. So there's this other thing. Rejected. Rejected probably on two main grounds. The first one is you're nowhere near medically stable enough for us to treat you. I'm just going to use diabetics as an example. So we know in diabetes that blood sugar is measured, okay? And we know what those measurements are. And it revolves around this thing that everybody refers to as HbA1c. All you diabetics watching, you've heard of this before. If the HbA1c is above 50 and ideally not above 60 and ideally not closer to 50, we know something. Their healing is not predictable, which means the risk of things not working or needing, even worse still, a secondary revision of surgery. Why anyone would want to take that gamble, I have no idea. The great thing is, HbA1c, with effort on the part of the patient, on the part of the diabetes sufferer, and some good advice and medication management from their medical professional, they can get it to 60 or under. We just need that window to get you there. We just need you to get to the other side. And anyway, it's a really good thing to have your HbA1c under 60 and ideally around 50 or less if you can get it. That would be fantastic. And it's actually a huge benefit to your general health, let alone what we're going to do inside your mouth. So that's one. The other one, medically, is the drugs. We always ask people for a medical history. Tell us all the drugs you're on. We're not asking because we're nosy. We need to think about the drug interactions with the drugs we're going to use, because they all have interactions. Am I correct?
Yeah, sure.
That's number one. Number two, the list of medications you have can have an effect on how you heal post-surgery. For example, we could calculate that your post-surgery healing could be absolutely horrendous because of the drugs you absolutely have to be on to stay alive. This is why we have a GP as part of the team, because Nitesh reviews every single one. And when advice is necessary, I know that some of you will have been contacted directly by our GP and they would have talked you through things, because we're trying to find a way to make it as safe as possible. But when the drugs list is that long and there's 5 things on there that are definitely going to interact with our drugs that we're going to deliver, because we're going to do the whole correction in 2 or 3 hours, which is quite an aggressive surgery. But it is the difference between getting it all done in one go and then staging it over months and months and months. Of course I want to get it all done in one go. As a surgeon, I just want one surgical intervention. Every surgeon in the world wants one surgical intervention. But sometimes, if once is not the safest route, and it has to be staged to allow your body that's heavily compromised because of all these drugs you're on for perfectly good reasons, it has to be staged. Then it has to be staged. The other one is dentally. Why do we reject people when they send in for reject? When they send in their photos. Okay, so I'm going to show you. Let's see whether this cable will actually stretch. I'm going to have to move it here, fellas. I know I'm blocking the camera, but tough. Right, that's me. Right, okay. So here is a photo. Somebody sent this in. Now, I have to say that looking at this photo, that looks like a pretty healthy mouth to me. Okay, yeah, all right, there's a crown there, there's another crown there, but they all look like they line up quite well. Great. Bam. Should I be taking all these out, or should I be saying you probably need, if anything at all, a single implant just here? Okay, so that's that. But then they send more photographs. This one. So I'm looking at the gum architecture between the teeth, and it looks really stable. Stage 1 periodontal disease, if that. Is there even stage 1 up there, or is it really stable?
Stable, healthy, growing gingiva.
That's good. That's a very strong indicator that we should not be taking these teeth out at all. Then we have this. Here's what's fascinating about this. We can see that that is where the crown of the tooth, the natural crown of the tooth ends, and this dark brown here, that's the root. Okay, the root is exposed, and it does have calculus buildup on it, and they're probably going to get loose. But look at that one, and look at this one. Seems to be, what's happening here, seems to be really stable. Seems to be really stable. So in my own mind, I'm thinking, why am I taking everything out? So the advice to this patient was, if you need anything at all, it's probably sectional implants just to address this area and the gap here. And no, we are not taking out the rest. Oh, but I don't like it. Yeah, I don't like it is not a reason that I'm going to buy. I don't like it is not something that I want to deal with. Look at that gum hill. It's excellent. That there is a bit of calculus, needs cleaning, but otherwise, do you expect that gum tissue to come back beautifully? I'm not taking them out. It's just out of the question. More. Okay, I told you about that. That needs to be addressed. Okay, those two need to be addressed, but I don't need to take everything out. No, this is not a rejection. This is bloody good advice. Great. Generally great. They're tipped in slightly. There's a bit of movement here, but it's not catastrophic. How easy is that to correct? And do you even need to correct it?
And as far as it is not causing any trauma to the tissue, it's fine.
Correct. So we don't see anything other than very, very, very localized disease, not generalized disease, which is stage 3, stage 4 periodontal disease. This is very localized and it's wrong. And then I look at the x-rays. That one's keeled over like the Teeming Tower of Pisa because somebody took this one out, and that's what teeth do. This is a phenomenon called mesial drift. So they don't just move forward like that, they tip into the space. Okay, but generally the bone levels look pretty good. Why are we taking these teeth out? Can't see the reason to do that. Okay, that one's had root canal treatment. So what? Bone levels look really stable. Okay, we've lost a little bit of the peak of the bone, but still no reason to take it out. Definitely not. Okay, on the other side, there's a lot of work here, a lot of root canal treatments. Root canal treatment wasn't because of periodontal disease. It was because of tooth decay. Ate too many sweets. Tooth died, but bone levels are stable. Periodontal disease is very specifically looking at bone health under the gum. If they're this stable, that means we don't have a cleaning issue, and we don't have the inability of saliva to reach the nooks and crannies. Otherwise, we'd have lost more bone. Am I correct? They're fine. We're not going to take these out. But I want them. No! Absolutely not. No! I don't know how many of you are watching this, but if I had stage 3, stage 4 periodontal disease, I would kill for those teeth. Wouldn't you?
They look better than mine.
They look, right. I want you to take all my teeth out. If I had a headache, would I ask my doctor to chop my head off? Or just take a paracetamol? No, we're not doing it. This is wrong. What is wrong with this? Okay, I can tell you now, see where it's yellow up here? You know what this is? Bit too heavy-handed with the toothbrush, like they're scrubbing the kitchen floor. It's not the kitchen floor.
Aggressive brushing.
Classic, isn't it? Classic, heavy-handed with a toothbrush. Oh, but I'm brushing my teeth really hard. That's the problem. It's a bit like cleaning your face with a Brillo pad. I'm sure it gets it really clean, but it buggers up your face. Yeah, don't do that. I mean, seriously? You want me to take these out? I feel rejected. Tough shit. I don't care. Okay? No! There's nothing wrong with this. This actually came in as an inquiry, didn't it?
It's a common misconception as we know the aesthetics of our solution is always great, but that is a secondary concern to the actual
It's a consequence
need.
of the fact that we eliminate disease and stabilize function. It's not the reason we do our job.
Yeah, definitely.
How much healthier do you feel?
Absolutely healthier.
I-
More energy.
More energy.
Feel better.
You know, I know they refer to you as the Croatian George Clooney in here, which I know swelled your head.
I
Right?
haven't heard that
But is
one
that the reason?
Nobody's ever told me that.
They won't tell me this. Okay, but is that the reason you had it done? Is that the reason you had this correction done, to become the Croatian George Clooney?
No, not really.
Right. What is the reason you had this done?
Suffering for 20 years.
Pain,
Pain.
can't eat, infections, blah blah blah, yada yada yada.
All problems.
You just
All the
happened to, as a side effect, become the Croatian George Clooney, correct? That's just a side effect, but that's not the reason we started on the journey. I mean, come on, what, are you kidding me? I'm never, who's going to take these teeth out? Who? It's criminal. Right, okay. Hey, I don't like the crown. Change the bloody crown. Easy. Okay, now we get into the people we are designed to exist for. They're gone. Yes, active, stage 3, stage 4 periodontal disease, active. The biggest concern is not actually the mobility of the teeth. The biggest concern is what's going on down there. How many bugs are entering his bloodstream?
Millions and millions. Yeah, we can't even count.
As a medical professional, how can that be doing him any good at all? It's a bit like having a rusty nail stuck in the side of your head. Oh, it doesn't bother me. Yeah, it bothers me though. Because you've got a rusty nail stuck in the side of your head. It is active periodontal disease. Okay, he's got no teeth. Should we treat him? Does he need what we do? Yes! No doubt, no debate. Is anything in the right place? Right. Why is it important that they're in the right place?
If they're in the right place, we don't need to.
Okay. But why is it important that we need to get them to a stable alignment? Because we need mastication to work properly. We need chewing function to work as it was designed to work originally anatomically. And the more inefficient that chewing function is, they don't actually chew more. They chew less. Which means the food going down is now bigger. And if the food going down is bigger, then the stomach's doing more work. It's producing more acid. And that acid can only go one of two ways. That way, heartburn, and that way, irritable bowel syndrome. Fix the blender, and guess what? Everything works. It's not difficult. It's one tube. Starts with the blender. Everything goes in that way. That's not going to work. And as for the denture that he is definitely wearing in his top jaw, because he won't leave the house without it, how much is it destroying the jawbone he's got left?
90 to 95%. It's taking everything for us.
And yet this is what we were taught, right?
Yeah. Put on the dentures, get them back. They look healthy. It will work for a long time. But no one tells them the consequences of wearing a denture.
People are not speaking about the consequences of wearing dentures. I live on planet Earth the same as everybody else. I understand costs. I understand affordability issues. I just don't think we should not be telling patients about the consequences of long-term denture wear. That's free information. It's not scaremongering. It is fact. Which denture does not destroy bone?
We did.
There is a denture that doesn't destroy the bone. It's the denture that never goes in the mouth. So, if you just have it on the sides, above the fireplace. Is that where yours sit now?
No.
Or have they gone in the bin?
I've got mine with a hammer. Hammered mine.
Brilliant! Brilliant, that's where they belong.
Yeah.
Smash to hell, all of them. You can't leave them like this. You've got to do something. So please understand that when we reject, we actually have sound medical grounds to do that. If it's dangerous to treat you medically, we ain't going to treat you. We're the experts. It's not a two-way conversation. It's a one-way conversation. No, this is too risky for you with your medical health. Sorry, no. And then it's the dental conversation. I am not going to take out somebody's healthy teeth because they don't like it. They don't like it. Okay. Right? It's still not a medical reason. The medical reason is I need clinical grounds, as in, is there active disease? Is there a compromise of function? Is it necessary to do this to this human being? Are they mentally prepared for that journey? And is this the right answer for them? We have to make that decision for you. So this is the whole needs versus wants thing. There's a lot of things I want. There's a lot less things I need. You understand? I'm in the need business, not in the want business, and we really have to, you guys have to understand, we're not rejecting. We're giving you some bloody good advice. Don't do this. Or, you don't need us. You need this instead, which is a lot less invasive, takes less time, is a cheaper. Go do that. No, I want you to take all my teeth out. No, it's not gonna. So please, pretty please put sugar on it. Stop fighting with us. I want you to show us one that's got very little bone. The so-called dreaded very little bone. There we go. We're just looking at a lower jaw here, right? It's the same in the upper jaw. So we've been over this before. Those lines there. Can you all see me clearly? Is my fat head in the way? Or do I need to? Is that okay? Fine. So we've got the nerves coming through the jaw, in the lower jaw. They come out here and they go into the lip. So we try not to work in the area behind where the nerves come out. We work in the area in front. And we can clearly see with these, they're all over the shop. Now, because this movement has been incredibly gradual for a very long time, the patient doesn't notice. But then there's a reason why they came to us in the first place, because things aren't working as they should be. And this particular person was told they don't have enough bone. I mean, you're in the planning team, right? Is this like a gift from God for us? As in, is this tons of bone for us?
Yeah, it's just like pure gift. It won't take like more than 10 to 15 minutes to plan for this. It's a lot of bone for us.
For us, it's a lot of bone.
For them, it's nothing. For us, it's just like.
For us, it's like, oh my God, this is so easy, right? Right, but I've had colleagues here from all over the world go, oh, are you finding the bone? Yeah, we're hunting for every millimeter we can find, that's why. And we need 8 to 10 in height and 4 in width. And we can do this. So that's what we're looking for. But the deep analytics on this software allows us to go and check every square millimeter of what is available. So when we say to you, we've put you into planning and we need a few days, it's because we're hunting around your jawbone for the best that we can find and make sure it strategically fits the implant complex that we know is going to work best for you long term. So it's not fobbing you off because we don't know the answer. We want to give you the absolute right answer. We don't want to give you an outline answer. We want to give you the exact answer and go, this is what it's going to be. And it's really important for me that patients who are considering this journey and definitely then go on to live with it should know what's going on in them and also the science behind what's going on in them. You're going to live with it. You've become a bit of an expert, haven't you?
I learned a lot from you.
Well, you also learned a lot from what you live with.
Yeah.
Correct?
As well.
That seems to be a pretty good educator, doesn't it?
Yeah.
So you transitioned fully to prosthetic state how long ago?
A year ago.
A year
Exactly,
ago?
Yeah.
Tell me how many times a day you thought about it a month in and how many times a day you think about it today.
I've first couple of months.
Permanently
Yeah,
fiddling with
yeah.
it with your tongue.
Yeah, exactly. Yeah. And some things I didn't, I couldn't adjust at that time. But now, it's just a part of.
You wake up and
but
it's just
never,
you,
never,
right?
Never think about it anymore.
It's not even, and that's the journey.
Yeah.
That's the prosthetic rehabilitation. That's the transition to prosthetic state that we always talk about because it is a transition. It's exactly the same as a hip replacement. It just feels really weird and awkward and difficult in the beginning. But as time goes on and the muscles recalibrate and everything recalibrates with you, it just becomes you. But we need the time. There are no magic bullets. Show me the plan. So first we set up the tooth positions, didn't we? So show me the tooth positions. Okay, so there's the tooth positions. So we can see that the new tooth positions sit inside the actual bone boundaries itself, front and back. This is called the neutral zone. I've spoken about it before. We have to set this first before we work out the implant positions because we need to make sure that everything sits inside what we call the prosthetic envelope, where the teeth should sit in relation to what is left of the anatomy, correct?
Yeah.
Right, okay. Then we've got these things, which are the implant positions. And if you notice, there's nice even spacing between them. So if I hang a TV on a wall and I bunch all the nails together and I've got big overhangs on the sides, it will just... But if I spread those nails out, then we get much more support. It's exactly the same principle. So we are working out the forces that you will put here when you're biting an apple and you'll put there when you're chewing the apple. And we'll go, okay, this is the load mechanics for this person, which is incredibly unique to that person. And then this is where the implants need to go. This is how we design the bar. This is how we make the veneer. This is how it all assembles on top. And we need to work all of this out, not as we get to your surgery, but actually when we speak to you within the first 7 days of your assessment and go, look, we've worked this out for you. And then and only then does it move on to the actual production cycle, which is a whole other story. These are the implant positions in the bone. Now this is a 13mm implant that you can see inside the bony housing. So you can see the very white bit on the outside is the thick part of the lamb shank, the cortex, the cortical bone, structurally very strong. And we like to lock into it as much as possible. And actually, we don't need more to lock into than 1 millimeter to give us immediate stability, to give us immediate function. 1 millimeter, that much, right? But when we get that much, how happy are you? Over the moon. Because you know that thing ain't gonna move in a 4-line gale, right?
Very tightly.
Yeah, but we've got the majority of our patients, particularly in the upper jaw, it's 1 millimeter of cortical bone fixation. And normally no more than 2 right at the tip of the actual implant itself. That's why some of you go, oh, I'm feeling weird twinges in my nose. Yeah, because we've locked into the nasal floor, because that's the most solid bone that you've got, and we've got to use it. But don't worry, it'll all remodel and it'll all just go away in time. It just needs time, that's it. So we planned it all. So this person was classically told that they have no bone, but for us,
Tons
They
of
have
bone.
huge amounts of bone, right? That's why it still bothers me. You getting this,
Yeah.
we have no bone. How many times a day I've been told I have no bone? Between all of you, how many times a day?
10.
10
15.
times.
But I mean, we can't blame them. We have to, because they have been told somewhere else. We can only show them what we know and what we do. And I can understand it in the beginning.
No bone is quite an absolute term.
Yeah.
Not enough bone for implants is another term, sentence. Not enough bone for the implants I want to put in the areas that have no bone is another sentence. Easiest of all, show them an x-ray and go, look, I've measured that and it's only got 10 millimeters. I can't work to 10 millimeters. Maybe other people could. 10 millimeters, we're talking about a centimeter. Okay, we can work with a centimeter, can't we?
Yeah, we do.
Right. If we get 15 millimeters, 1.5 centimeters, what's 15 millimeters for you? Is it the Suez Canal?
Yeah,
For you, it's that much
I can engage implant anywhere I want if I get that.
with 15 millimeters. Now, considering that the lower jaw, for example, on average for most people is around 3.5 centimeters or 3 centimeters,
Yeah.
you'd have to lose like 80% of it.
Yeah.
70% of it, 80% of it, because before we go, you know what, you've got no bone. And to lose 70, 80%, it's either major trauma or you've been wearing a denture for 40 years. A terrible denture for 40 years. And it's got to be a terrible denture. Or major trauma. Can we see that easily on the x-ray?
Everything is visible.
Everything's visible. But our x-rays are in 3D, which means you've got the full volume analysis, so you can see it all in
We can see
360.
every bit of it.
So I'm not buying this no bone thing. There's no bone, and then there's no bone for 21D.
Yeah,
Yeah.
true.
You know what I'm saying? No bone for 21D is like no bone. Which is why we still say to people, look, maybe you were told this, but if we're confident enough to invite you for a clinical assessment, then we're confident enough to know that we might find something to work with that could solve your problem.
I hear a lot. It's the sending photos if they think their teeth will appear to look healthy. There's a big fear that those will be quote unquote rejected.
Yeah.
At which point, go and get an X-ray. There's local scanning centres, anything that we're able to
Yeah,
see any further.
I think also it's important to say that before, just for myself, I didn't have any point of reference or point of education before I go here, so I didn't know anything about this, and I guess most of the people we don't know anything about. We kind of ask questions online, but we ask wrong people that are also
patients.
on the same level as me. We don't know anything, so we're just passing something to each other, and then we form our opinion based on that. But when I go here, I also, what I like what you said once, you are trying to protect people from themselves.
Yes.
I think this is really important and interesting subject for me, this needs versus want. Because people, they just go and they say, I want it all on 6.
I see that a lot,
And then
yeah.
and then the clinic will say, yeah, we will do that. But
When did it become a request?
yeah, exactly. If I go to the clinic and somebody says straight away, yes, I will do that, whatever I request, I will just walk out.
Yeah.
Yeah, I will just walk away, because no, you don't do what I say, because I don't know anything about it.
We work out what you need, and that's what you
exactly. And that's a really, really interesting subject, because I can see what's happening online and people saying these things, and yeah.
I think I covered this last week. I'm going to cover it again because it just. I was asking Stratos this when he was on with me last week. All on 4 versus all on 6.
Yeah.
Is
the
that
answer-
like Godzilla versus Kong?
It seems, yeah.
Because that's what it sounds like.
Yeah.
All on 4 versus all on 6. Do I have 6 screws put in my head, or do I have 4 screws put in my head?
With same function.
with exactly the same function.
Yeah.
Do I drill out 6 lots of me or only 4 lots of me to get to exactly the same place?
Yeah.
Is that really a question? When did it become a question? When did it become like a menu item? Hello, I'll start with the egg salad, and then can I have the all on 6, please? No. What?
Yeah, that's what's happening. That's what's happening. That's what's happening, unfortunately.
I think what bothers me about that, and I feel sorry for people when we see them. I mean, for me, it's nothing short of brainwashing. There was no education. 6 is better than 4. In what instance is 6 better than 4? If you mean drilling 6 lots of you out to put 6 lot of dead screws in is better than drilling 4 lots of you out and putting 4 dead pieces of metal in you for exactly the same function in the end, no.
Can we add a bit to that? Like, if the patient says, like, let's say for lower jaw, they want, they say like they want all on 6, but can we highlight them if we place another implant? Like, let's say in this case we have got 4 implants, so our like last implant is on teeth number 4. So if we go for 6s, we can tell them that how close it can be to the nerve. It can cause nerve damage as well.
Yeah, I'm even simpler than that. I said, of course you can have all on 6. You're going to get 4 in your jaw, and you're going to take these 2 in your pocket and put them wherever you like. I don't care. They're just not going in your mouth. Because I'm in charge of your oral environment, and I know better than you, and I am not drilling out perfectly healthy tissue because somebody planted in your head that it's better to have 6 screws than 4 screws. Fine. If that was the truth, then why was the first protocol in 1997 and still the global standard all on 4? I'll tell you how far we've moved. In certain cases, to avoid bone grafting, we can even do all on 3, and they work really well because we can put the titanium bar immediately.
All on 3, yeah. That's something.
Okay, but it's not all on 3. It's all on 3 in the jaw and a titanium strut across the jaw. Yeah. So that's, for me, even more than an all on 6.
Yeah.
You understand? In terms of mechanics,
yes.
That's what matters here. What matters is load mechanics. Will it take the load?
Well, I mean, like, barely the load will come on the implants. All the load, it will be distributed properly on, what do you say, like titanium bar.
If you hired 2 people to put a telly up in your house, and one said, I'm going to use 4 screws, and the other one said, I'm going to use 400 screws, who gets the job?
4 screws.
Why? 400's better, right?
No.
Destroy your wall, definitely, but 400, I feel so much better. There's 400 screws. There's no wall left, but there's 400 screws in there. No, this is just, it's marketing. Where is the science? Where are the rules of biology, which is universal, by the way? You ask any surgeon in the world, they will want to remove enough that is effective, but as little as possible to try and maintain as much healthy biology as possible. Is that universal truth in any surgery?
Everywhere.
I mean, I can't wait to read that thing about hips, you know? If you get a hip replacement, we're just going to put a spare one in, just in case. We're going to give you 4 hips instead of 2. What? I mean, is that even a discussion? I've got friends who are orthopedic surgeons, so I always ask them, do you ever discuss the number of fixation screws you put in a hip replacement? They looked at me like I was stupid. They just went, what kind of stupid question is that? The kind of stupid questions I keep being asked all the time. Why aren't you putting more screws? Because you don't bloody need them, that's why. And if you don't need them, we're not doing it. Because there is a long-term consequence to reducing the amount of natural tissue there is beyond what is necessary. If it's healthy and you don't need it, why are you drilling it away to replace it with something artificial? Sorry, this just... It's just, see, it never gets better. I've been listening to this shit for 27 years, and I'm still hearing it. I'm like, what are you? If you need 5, I'll tell you you need 5. If you need 6, I'll tell you need 6.
That's the point, that we know what's going to be best for them.
If you want 2 extra implants that desperately to feel like you're getting value for money, ask me. I'll just give you the 2 implants, but they're not going in your head. Just say, VJ, I want to feel like I'm not being shortchanged. I want all on 8, but don't worry, you can only put 4 in the mouth. Can I have 4 spare ones to carry around in my pocket? Yes, you can have them. Maybe some nice earrings, some cufflinks, whatever. But no, this all on 6, all on 8, all on. It's what is anatomically required to eliminate disease and stabilize function. The elimination of disease does not come from the implant. That comes from us cleaning all the crap out before we put the implants in. And then the stabilization of function is the load mechanics that's calculated not on a per implant basis, but across the entire structure that includes the titanium subframe. So we know that when you chew, it's going to be stable in function. These are totally accepted principles in orthopedic surgery of any other. Nobody in orthopedics, no patient says, how many screws are you going to use? It's not a question. But I live and die by that. How many screws are you going to use? However many I think you need. I want all on 6. Well, you can have all on 4 in the mouth, and here's 2 spare ones. Do with those 2 whatever you want. I don't care. You can have them. I'm definitely not shortchanging you on the implants. If you just want spare implants, just ask me. BJ will provide spare implants every single time. But we are not going to put anything beyond what we clinically calculate is necessary. We just don't do requests. Don't ask us. You'll just be upset with the answer. It will be a straight no. And that will be the end of that. Right, enough of my rant. What was the other question? I wanted to ask everybody another. Oh, yeah, here's a question. Seeing as you all like to ask me questions, I want to ask you a question. So if you've already put in, have we had people tell us where they are in the comments? Anybody put them in? Yes or no?
Yeah.
Have we had people tell us where they are in the comments?
Yeah.
Yeah, good. Okay. Here's my second question for the day. Can you take this rubbish off the screen, please? Just pull
Just
that out.
unplug it.
Yeah.
Just unplug it at the back. Pull it out. Great. Okay. So I've got a question for you. So I remember doing this with my master's students about 12 years ago, because it was really important for me to understand the optics of the clinicians versus the optics of the patients. So I created a list with 4 words on it. And those words were the following. Affordability, pain, time, and the time was time in the chair, number of visits, all that kind of stuff, and trust. And I asked the clinicians and patients. I asked a few hundred of my patients. I just gave them that sheet and I asked about 20 clinicians. So my question was, okay, we know that all of these things are important, but in order of importance, you, Mr. Clinician, tell me what you think is number 1, being the most important to the patient, going all the way to number 4, which is a consideration, but is not the most, it's the least important out of the 4. And I asked exactly the same of the patients. Now the outcome was really interesting. So the clinicians put the following. They said affordability was number 1. Oh, my patients can't afford it. I said, okay, tell me where you got that information from. That's what they told me. Right, okay. Do you think you did a good enough job explaining the value of why they turned up and asked for this in the first place? Or did you surprise them with the fact that they've got stage 3, stage 4 periodontal disease, even though they've been seeing you for the last 10 years and you never mentioned it before, when they had stage 2, for example? The The second one, they went, oh, yeah. You know what? They're all bothered about pain. Yep, that's a very human thing. Are you bothered about pain? Are you bothered about pain? Are you bothered? So it's not just patients. It's everyone. It's humans. They're all bothered by pain. The third one was time. Oh, you know, I have to spend as many visits as I need to spend with them to get it just so right. So I asked them to quantify it. Okay, how many times would you want the patient to come back? And they said, well, for this kind of work, I'd want them to come back about 15 times. You saw your dentist 15 times. Are you on his Christmas card list? Did they name one of the chairs in the waiting room after you? Did you want to see them 15 times? What did you want?
Never.
That's the word.
Thanks very much. Right? And then the fourth one was trust. Well, why wouldn't they trust me, Vij? I am a clinician. Yeah, like the 3.5 million other dentists in the world. I gave exactly the same list to the patients. And this is what I got back. So, by a country mile, number one was trust. So I decided to dig a bit deeper and go, trust who? Me or the science I'm telling you? And they thought about it and they went, it's a bit of both. So, but wait, all I'm telling you is the science behind what I do, and that's why you're trusting me? Because the science behind what I do, when I explain it to you, you go, that makes sense. So actually, it's not me. It's the science behind what I need to do for you, explaining it in a way that you can visualize. And then number two, shock horror, was pain. I know it's going to be painful. Well, you are in a mess. And there's a load of stuff in there that we didn't put in there that we definitely have to remove. Pleasant? No. Kill you? No. Necessary journey to go from disease to health? Yeah, in all aspects of surgery. Funnily enough, taking an appendix out that's inflamed. Painful, but necessary. Fact. It's just how it is. When we're taking stuff out, your body reacts, doesn't like it. Be it teeth, be it diseased bone, be it diseased gum, it doesn't like it. But it's all part of the process of re-establishing health. We have to do it. Then, of course, it was the time. And the main thing for them is, oh, you know what? If you drag me back 4 times, 5 times, I can get my head around that. 15 times? 15 times! Did your wife know that you and your hygienist were borderline dating every 2 weeks? Did she know? Right, I'm sure there's hygienists watching it. Listen, I have nothing against you lot at all, but 2 weeks? Every 2? What are you kidding me? Your wife at no point said, why are you seeing that woman so often? She never said that? Right, okay. And then it was this one. And I found this one fascinating. Because they said to me, look, BJ, it's a lot of money. I get that. I totally understand that. But you're not paying for some implants. You're paying for the expertise and the structure and the setup that's needed to get you from here to here. And unfortunately, we're not subsidized. We're not subsidized. This isn't government backed. I wish it was. Honestly, I wish it was. So if there's any politicians watching, you should be helping these people. Anyway, enough of my political rant. I'll get thrown out. And the affordability was only considered if the trust was established, the pain was quantified, and the time was quantified. Without considering these 3 things, it wouldn't matter if it was free. It was still not going to happen. So look at the difference in the optics. So the question I have for all of you is, on that list, right now, for everybody watching, in the comments, please tell me, what is the main objection? Is it affordability? Is it pain? Is it time? Is it trust? I'd just be curious to know what the audience thinks right now, wouldn't you?
Yeah, definitely.
It'd be great to find that out, wouldn't it?
Yeah.
But they never tell us when we speak to them on the phone for the first time. They're all a bit shady. Why do I need to give you my name? Because we need to know who we're speaking to.
I just want to know your name.
I just want to know your name so I don't have to refer to you as Oi.
Yeah.
So,
And they, why do you need to know my name? Because that's just how planet Earth works. Maybe. So yeah, please, pretty please with sugar on it. If you can just, in the comments, just tell us what your number one objection is. It would be interesting to get the feedback.
We got the answers. Trust for 80%.
There you go. There you go. There you go. Right there. 80%. Trust for the win. Bang, slam, dunk. Keep going.
10%. And affordability and time are on a tie, but in comments somebody said time first and then affordability. So
You see? And this was a survey done with my patients in 2012. Nothing's changed. And the main thing you're trusting is not us. You're trusting us and the science. We clearly explain to you all. This is the key. The key is make sure you understand the science. Educate yourself. We are trying our best to put all this information out there so people can be armed with the education. It is really important. Then all of a sudden, the bullshit about all on 6 doesn't matter anywhere near as much as what is the science behind what you're going to do. Explain to me in a way that I can understand what my body has to go through to get from here to here where I need to be, so I can begin to quantify it and understand it. But that was quick.
Yeah.
Overwhelmingly correct, as I thought. Right. Questions? Maestro.
Could you explain the issue with the underbite?
Right. Okay, so let's think about it this way. This is the top jaw, this is the lower jaw. This is what everybody refers to as an overbite. What would you say? About 5% of the human race is born that way? Yeah, about 5%.
Yeah.
Maybe 10, I don't know. I'm not an orthodontist, right? And actually, if it can be addressed, it should be addressed with orthodontics, where the lower teeth go in front of the top teeth, and it should happen in childhood, okay? And we can have extremes of underbite, so the upper jaw could be very far behind. So the further behind it is, what we need to do is not just some simple tipping of teeth. We have to do something called orthognathic surgery, which is to break the jaw, reposition it further forward, and plate everything together. It's not pleasant. But it's done a lot for that underserved population. That's the underbite. We aim to get you to what you refer to as an overbite. Why? Because I want you to think of it as a pair of scissors, okay? So your front teeth are for cutting. So you want the scissors to pass each other. You don't want the blades to hit each other, and you don't want them to pass each other too far apart, because then you can't cut anything. So we're trying to calculate all of this when I work with Hamza and the team to work out what we can get away with, what we can get you to that would be efficient without messing with your muscles. So if you have an underbite like that, and I just tip you forward like that, the main place you feel it is not at the teeth, it's at the lip. Because now it's further forward than it used to be, and your lips suddenly doing the Elvis lip thing. Well, I can feel that. Yeah, you can feel it on day 1. You probably feel it in week 1. You probably feel it in month 1. But you know, by month 2, because it's in exactly the same place, your muscles will readapt. And you know, by month 6, if I put you back to where you came from and you were in for 30 years, you'd go, oh, this feels weird. And I'd go, well, that was just 6 months ago, mate. It's all about that recalibration. So that's the underbite thing. It's what we call a class 3 bite, and this is a class 1 bite. It's all to do primarily with the relationship of the top jaw to the lower jaw. And it's a developmental thing in almost all instances, and it should be addressed in childhood. With orthodontics or orthognathic surgery. It's a bit late to start jiggling about with it. We can a little bit if they're not that far apart and just need to flip over. But really deep underbites should be surgical correction of repositioning the jaw, and it's dicey to do that at the age of 55.
Yeah. I'm booked in for FCA with 21D, but I'm concerned because I already had sinus lift and bone graft.
Why are you concerned?
So what's going to happen?
Okay,
at
the
that
first
year?
thing we're going to use is not your sinus lifts and bone grafts. We're going to find your native bone, just like I showed you before on this screen. For me, I've done sinus lifts. I think people forget this about me. 27 years ago, I did what everyone's still doing to this day. Lots of it. Lots of hip grafts, lots of bone grafts, lots of sinus lifts. My problem with it was their structural integrity in heavy loading. So I'm talking about suspending an entire jaw, not one tooth, around other teeth. I'm talking about suspending an entire jaw, and half of it is in bone that's not native to the person. I've either used artificial materials or I've detached some bone from somewhere else and plated it into the mouth, and I'm working with whatever's left. And in my experience, it's not as predictable as using native bone. So even if you've had sinus lifts, that's not where we will be looking to. We'll be looking to what native bone you already have. Now, in my experience, particularly for the strategies we use, using what we called axial implants and tilted implants, we can avoid it. But that's just us. That's our expertise. I can't speak for someone who's done 100. I can only speak for someone who's overseen tens of thousands of them. And in that journey to the tens of thousands, we found that it was very beneficial to avoid bone grafts wherever humanly possible. And that's what 21D does. So I wouldn't worry about it at all. Just turn up, let's take our scans, and then you're going to go bone hunting, aren't you?
Yeah.
She's gonna receive a call from us.
Yeah.
More than likely.
This is the last question. What does a bespoke surgical plan involve?
Exactly what you saw on the screen earlier. So we look at your anatomy and we work out the best places to put everything for you with the anatomical structure that you have. That makes it totally bespoke to you. It is totally individualized. Oh, my mate had 5.
No.
I mean, you could be identical twins. You still won't have exactly the same plan. It will be based on your individual anatomy. I want you to think about it this way. Everybody wants to end up in the same place, but they can't all end up with the same smile because they all didn't start with the same smile. That's one thing. The second thing is, your face is unique to you, which means the plan we do inside your face has to be unique to you. That is the definition of bespoke. It's one-offs. That's why we have the setup that we have. That's why we have a dedicated planning team that's full of dentists who just sit there all day, just individually, anatomically planning the work. Could we do a size 7 shoes for everybody thing?
No.
Because if we could, I'll be calling B&Q. Because I'll go, I've cracked it. Here you go. It's all in this box. Just fits everybody. Yeah, that never works because it's not a shoe.
Yeah.
For starters, it's so complex. There are so many variables. There's so many things that need to be thought about for every single person, and it has to be tailored to them. Otherwise, why would we use such precise surgical guides? Why would we use our own custom-made implants? Why would we make plate technology prosthetics if it was all one size fits everybody? Yeah, it's the difference between something working predictably for 10 years and something working predictably for 30 years. And I just don't see the point of this journey if I can't predict all the way to their last day. And I know this. I'm seeing patients in their 50s, and I'm seeing patients in their 80s who are as fit as a fiddle. So when I see the patients in the 50s, I'm thinking, you're just entering middle age? So I know there's 30 years of 3 meals a day to go. There's 30 years of weddings, bar mitzvahs, funerals, christenings, all those selfie opportunities. I know that And it's not good enough if it lasts 5 years. We have to look for it and think and make decisions as a clinical team that it's going to last a lifetime. You speak to them when they first ring up. How badly do they want it to work forever?
Very, very badly.
Yeah, that requires a lot of thinking.
Absolutely. Yeah.
That requires a hell of a lot of planning, meticulous data capture. Yeah, okay, sometimes I'll say, bring them back in again. Take more data again. I'm sorry if it inconvenienced you, but please understand why I'm doing it.
I've seen it a handful of times in the time I've been here. It's very rare that has to happen.
Yeah, but sometimes it's necessary.
Sometimes, yeah.
I get moaned at. Oh, why is he asking me to come again? Because I bloody need you to. Because I'm trying to make something for you that's going to last the longest amount. You're chastising me for this? Trying to be nice here. Okay, you've spent some petrol money, but I'm going out of my way here to make sure it's bang on for you. So please understand this. Bespoke planning is the cornerstone of 21D. There is no one size fits all. We take it we do not treat you as patients. You all have names. You all have unique set of circumstances, medically, dentally, psychologically. We consider all of these things, and we're making something that's tailored to your absolute need. It is really important that you work with us, because we're only trying to get you to the best possible place we can get you long term and call an end to the misery that you've all gone through already to get to us.
Yeah.
Okay, if you have to come 2 extra visits for us, how does that compare to the hundreds of visits you went before and nothing was achieved? I'm suddenly the bad guy?
Yeah.
Yeah.
Wow, okay. Thank you.
Yeah, thank you. for
And
having me.
thank you.
Thank you.
And as always, thank
Cool.
you.
And
Thank you very much for joining us. Looks
Thank
like
you,
we've
Vijay.
overrun by 6 minutes and 47 seconds. Sorry, fellas. Thank you all very much. Tune in again. Bye.